Connecting to cloud server. Oh, it's starting to record. Okay. So I think now it's recording. Good. So, hello everyone, and thank you for joining us. We are Tarini Jori and Ravish Mishkov, members of the new AO Spine Youth Club. And we welcome you to the History Insight series, where we interview the pioneers of spine surgery who generously shared their professional and personal experiences with us.
And today, in this interview, we are deeply honored to welcome Dr. Atul Goel, a true luminary in the field of neurosurgery. Dr. Goel's career is marked by groundbreaking contributions, many at that. In this interview, we are going to talk about the C1C2 arthrodesis technique that he published in the year 1994 along with Dr. Vinod Lahiri. This revolutionized the treatment of craniovertebral junction abnormalities. Dr. Atul Goel stands as an eminent figure in neurosurgery, holding prestigious positions in many institutions. He is a consultant neurosurgeon at Leelavati Hospital. He was also the former professor and head of neurosurgery at the most renowned medical institutes like the King Edward Memorial Hospital, as well as St. G.S. Medical College. His work, recognized by multiple awards, one being India's highest medical honor at the hands of the President of India, the Dr. B.C. Roy National Award. This further validated by his extensive publications and top global rankings by Stanford University, where he is recognized as number one in India for neurosurgery and neurosciences, number one globally in skull-based surgery, and among the top 0.4% scientists worldwide. And this list can go on and on and on, and then that's all we'll be able to cover in this interview. So avoiding that, over to you, Raris.
So we are just incredibly fortunate to have him with us today and to share his invaluable insights and experiences. So thank you again, Dr. Goel, for joining us. So let's begin the interview. Tarini?
So, sir, as you know, the AO Spine Youth Club has a spectrum of members. Many of those have newly joined to spine surgery. So, if you could briefly explain what your C1, C2 fixation technique consists of for those members, it'd be great.
Okay, Tarni, thank you very much for inviting me. I am very happy to be with you, and I hope my talking can influence some young minds and young brains and young hands into getting into more than what they are doing. I must also say that I was very fortunate to be able to work in very big public institutes of our country. And that gave me an opportunity to operate and operate and operate continuously since the time I entered into this field of neurosurgery. And I think that was the turning corner of my life in neurosurgery because I got those institutions. Second thing is these institutions were not just institutions by stones and by walls, but there were tremendous people working there, tremendous anatomists, tremendous philosophers, tremendous colleagues, tremendous seniors, and that gave an opportunity to be amongst the stars and amongst the stalwarts. So that was the fortunate part. I don't consider myself to be an extremely intelligent or something like that, but I have been very ambitious. I have been looking ahead. I wanted to achieve and I wanted to go beyond the line. So when I was in joined KEM, the most important thing in my career is that I got involved in cadaveric dissections quite a bit, quite heavily. And my other thing is, as I mentioned, my colleagues like Dr. Lahiri, Vinod Lahiri was my senior in orthopedic surgery, and he was also one of the mega stars of cadaveric dissections. He was a senior orthopedic surgeon. And during that time in 1984, 85, orthopedic surgeon did not include too much of spine. They were just Colles fracture or femur fracture or humerus fracture. That was spine surgery for orthopedics. I think Dr. Lahiri's contribution in spine surgery and his work on spine surgery had a big influence on the entire generation of spine surgeons in our country at least. and also in the world. In Mumbai in particular, you see many spine surgeons in Mumbai heavily influenced by Dr. Lahiri, because at that time, neurosurgery, of course, we were doing all these kind of spine and craniovertebral junction. So during that time in 1985, 86, when I was a young, not even graduated in neurosurgery, I got several opportunities to do cadaveric dissection with Dr. Lahiri. So my collaboration with him was the real turning ground for me. You know, in neurosurgery, we were never exposed to, we did not know what are screws. Even many neurosurgeons, even till date, do not know what screws are. And fixation means, bone fusion and all those things were, not so well understood by neurosurgeons. And this was a domain basically of orthopedic people. So my collaboration with Dr. Lahiri, he introduced me to screws. He, he was amongst the very senior, very initial ones in the country, at least, to do lumbar screw fixation and all those things. And his work was very well recognized by even Steffi, who visited India in 1987. Dr. Lahiri showed his work. And so my introduction to screws and my introduction to heavy cadaveric dissection was a great influence from Dr. Lahiri. And we were doing craniovertebral junctions surgery. I was not particularly, I was a junior guy, but I was assisting and I was participating in my department, which was well known in craniovertebral junction surgery at that time, and even much before my times. So when Dr. Lahiri started doing for lumbar spine, we got an idea, why not in craniovertebral junction? That time, the only advanced technique for craniovertebral junction surgery fixation was wiring. Wiring was the ultimate. There was nothing beyond wiring. So that collaboration, that work on cadaveric dissection, that kind of enthusiasm and that kind of perseverance led us to getting into this technique of C1, C2 fixation. And then, we did first case in 1987, 88, we did, and our publication during that time. The other thing in India was the publications were not very popular. To publish your work was not so common thing in India. So from 1988, I tried to publish this technique in several journals. I sent to Journal of Neurosurgery, I sent to Neurosurgery, I sent to Surgical Neurology, which was a big journal at that time. I sent to Spine Journal. So various journals I sent. And you know what? Despite number of beautiful images, this paper continued to be rejected, then again sent, rejected. And Acta Neurochirurgica, in which we published our article first in 1994, was not such a huge journal at that time. It was relatively a minor journal, but they published our article in 1994. And as you might know, that this article is amongst the most highly cited article in the entire field of spine. And as you rightly said, that this article has completely, let me show you the image of this. Just a minute. So this is, can you see the image?
Yes, sir.
So this was the technique that we published in 1994. First case was done in 1987, based on cadaveric dissection and all those things. So one screw goes in C1. Even I must say that during those years, early in my career, what facets. Now, of course, if you know my subsequent work, you will know how much I have been involved in understanding facets, how I have completely worked with number of articles on facets and facet problems and all those things. But during those days, facets were not very, because imaging was not good. Facets were not really understood. The strength of the facet and the strength of purchase of the screws and introduction of screws and instrumentation. You see, this plate that we used at that time was radio-ulna fixation plate. That radio-ulna plate was there. So that stainless steel plate was we used, and that was cut, and that plate was used for, to do this, and then screws. So this was quite a anatomical precision technique. And also you must know that the anatomy of this area was difficult to understand. It was not such easy because of the location of the vertebral artery. Another very, I'll give you this slide. This is the slide. You see, there is C2 ganglion here. See, this is the C1, C2 articulation. C2 ganglion is a very unique ganglion. It is extraspinal and it covers the C1, C2 articulation. So this ganglion is quite a big, it is the largest ganglion in the spine. And this ganglion covers the atlantoaxial joint. So we described at that time to cut C2 ganglion and expose the joint. I think that understanding of the C2 ganglion can be cut, C2 ganglion can be cut to expose the joint. I think that window of the atlantoaxial joint can be the major landmark issue in this surgery, where you can admire the courage of the surgeon to cut a large ganglion. First is to find out whether it has some function or not. Second thing is find out the relationship with the C1, C2 joint. And second thing is the ability to and having the, power to cut the joint, to cut the ganglion to expose the joint. I think this was also one of the very landmark kind of a situation that we entered into, and then we did this C1, C2. Of course, over the next 35, 37 years, I have personally done more than 4,000 cases of C1, C2 fixation. And this 4,000, it is such a strong technique. My technique since beginning, since 1988, involves opening of the joint. You see, who would, amongst the bleeding situation, so much venous, and that time microscopes were not there, lights was not there, lighting to have this exposure was not proper, and the instrumentations were not so, bipolar instrument was not there to be able to expose the joint, to put bone graft in the joint, and then do C1, C2 fixation. I think this was an anatomical jewel that we landed into. And when I say I have done more than 4,000 cases, this is where 4,000 means I have given 4,000 new lives. When you are able to do good C1, C2 fixation, when you are able to do a successful C1, C2 fixation, you give new life to the person. From dramatic symptoms, from dangerous symptoms to complete new life. So this technique, which is now, as you know, very popular throughout the world. The other thing I should not or may not or is not right to mention, you see, we described this in 1994. But this technique, and many case reports, many book chapters I wrote from 1994 onwards, many lectures, many workshops. But this technique was described, similar technique, as you know, by Harms in 2001, 7 years later, where he used, instead of monoaxial screws, he used polyaxial screws. And those screws were Medtronic screws. But for whatever reason, he published in Spine, journal Spine. And from that point, this technique has just taken off. Initially, people didn't know of my publication, but when this paper was published by Harms, then I wrote about our paper, and ultimately now it is called Goel Harms technique or whatever technique. But this is our technique. This is mine and Dr. Lahiri's technique, without any doubt and without any question. And this technique has not only revolutionized craniovertebral junction surgery, but to tell you the truth, it might have an effect on revolutionizing the entire spine surgery. Because what we are doing here is we are stabilizing the facets. Basically, facets are the strongest point of the vertebra. And facetal fixation Although Goel's technique, which was exist in 1982, he described transarticular fixation technique, Goel's technique, he used facets. And then Roy Camille also described transfacetal fixation screws, Camille's technique of fixation. So they use facets, but facetal to use facets has not been so popular in spine surgery. And my feeling is craniovertebral junction, of course, the facets are the key points in craniovertebral junction, but even in subaxial spine, facetal fixation has a great role, an underused role, and the strength of facet has not been really capitalized. Okay, so now for your questions to me.
Sure. Oh, this is a beautiful overview. So you went nicely through the challenges that you experienced with it, and we'd like to ask about why did you feel that the existing methods at that point were not enough before you came with this technique?
See, at that time, actually, as I mentioned to you, sublaminar wiring was the technique. And many of these infants and young children have very cartilaginous kind of C1 arch or absent bifid arch. And sublaminar wiring could not be used for C1. So we also talked about using occipital screws. For the first time in the literature, we used occipital screws in 1987. See, occipital fixation screw, occipital-cervical fixation technique is now a very commonly used technique. But how many people recognize that occipital screws were used first by us? The other thing that many people do not recognize, but inclusion of spinous process screws. You see, C1 and spinous process and spinolaminar screws were also described by us in 1994. So we have described other techniques like double insurance, one screw in C1 and one C2 screw like Megel's technique. So to answer your question, at that time, the only technique was sublaminar wiring and also some kind of metal loops were then came in picture like Ransford loops and Herschel loops, rings and all those things and tying wires with the Herschel ring. Those also had become popular at that time. But as you know now, all those wires are completely and absolutely very rarely used, only in situations where you're not able to do this kind of fixation. Also, subsequently, we describe intra-articular spacers to put spacers in the joint to distract the joint for basilar invagination and to have a stabilization of the C1, C2 using intra-articular spacers we described for the first time. We also describe spacers for subaxial spine like intra-articular facetal spacers, facetal distraction technique. I think those techniques also have, at least not now, but future role in the treatment and understanding of degenerative spine, understanding of OPLL, understanding of various other issues in the subaxial spine. So as regards C1, C2, I think as I mentioned, we started doing in 1988 or 87. I was a very young, so actually we started off with these techniques. I have personally not been involved too much in wiring and all those things. My craniovertebral junction journey has actually started off with this kind of technique fixation. I mean, I have very rarely, I don't remember too many cases of subaxial wiring that I personally used. So in 1988, and from then, just the whole thing went on, and I think the journey is ongoing.
That's incredible. So even the introduction that you gave us, it was so interesting. It was like listening to a storybook, especially knowing that actually the technique was developed since 1987 and actually then published at 1994. Also, out of curiosity, and if you don't mind sharing, assuming you and Dr. Harms met, how was the first meeting like when you both had discussed that about this technique and the publications?
Yeah. See, I think whatever said and done, Harms is a very senior, very respected spine surgeon. And whatever said and done, I had published in 1994, and I had published several other articles after that. Several, you can see, go through the literature and you find many more articles till Harms published in 2001. But he had the power to popularize it. So I have to compliment his work and compliment his contribution. And when I have met on several occasions, and he is, his face is such a respected and respectable face that I admire him and I respect him more than anything else. Only thing is, uh, actually, there is no only thing. So he is he, and I. Well, other thing, what, from India, also you must understand, to in India, publishing was not an art. And publications were not, even if somebody publishes from India, they would not even look at it. I think that is also one reason because this paper was not so popular, despite the fact that it was published 8 years earlier or 9 years earlier, and on the basis of several cases. So, and also there are so many pictures and all those things. You see, that is the thing. But whatever said and done, Dr. Harm's contribution in this field, and he popularized the whole story. And I have nothing negative about his contribution and nothing negative about his personality and his persona. And I respect him not only for this, but his heavy contributions in rest of the spine. He's got so much other contributions, and probably he was considered as complete king of spine during those days. I'm not sure his status now, but Harms was a very big and respected name in the field, and he actually helped me come into picture and popularize my technique.
So, also to ask, once this, you talked about the challenges that you had faced during this, and why did you feel that you had to create a technique for C1, C2 stabilization? You already discussed that. So, if we were to jump, how was the first patient? How did the first patient do? And did the outcome match what you had envisioned?
See, this technique is a technical, as I told you, I have done 4,000 or more cases now. Today also I have done one case. As I grow in this field, I'm getting more and more complex kind of cases, more and more difficult kind of cases. But if you are able to do this fixation, the fixation is so solid and so strong that the results are absolute. Only thing is you should be able to do it. And it is not an easy technique. Even today, if somebody says, many people try to avoid this technique and they include occipital bone. Occipital cervical instrumentation is so popular. Nowadays I say that inclusion of occipital bone in the fixation construct is a suboptimal fixation. But many people try to do occipital fixation, occipital C2 fixation, because they are not able to do C1 fixation, or they have difficulty in doing. And some people have difficulty in exposure of C1 facet. So they do Megal's technique using C-arms and all those things. Megal technique is a good technique. I'm not saying it is not a good technique. But this technique, when you can have such a huge purchase of C1 screw inside the whole of facet of C1, you have the possibility of manipulating the facets. I'm not sure if you have read my work on manipulating the facet. We treated rotatory dislocation by manipulation of facet. We treated basilar invagination by manipulation and distraction of facet. We were the first one to do that. And also there was an entity called irreducible dislocation or fixed dislocation, fixed atlantoaxial dislocation. We first said that there is nothing like fixed dislocation. They are all unstable. And the joint you can open, manipulate, and realign the joint. So this concept of realignment we introduced. So this was the beginning, but we have gone much beyond over the years. And you must read my further work on craniovertebral junction, which is ongoing. The things are still beautifully now. We have introduced a fantastic concept of central or axial atlantoaxial dislocation. We find atlantoaxial dislocation as the cause of Chiari malformation, as a cause of syringomyelia, as a cause of Klippel anomaly, as a cause of torticollis. So many issues. So I think the journey has been ongoing and journey has been fantastic. And I have said earlier that if I have done 4,000 cases, I have given 4,000 lives. So that is my power. Now you ask me how was the journey, how was the first case? All cases, you see, there can be complication in any case and every case. But this operation is outside the spinal cord. The main issue is vertebral artery. If we are able to save the vertebral artery, the complications are very few and far. So I in the initial cases with the dramatic results that we got, I think it only encouraged us to go further and further and go on doing. As I mentioned, I was just 26 or 27 years old at that time to get opportunities to do these cases. To go in the operation theater and some senior tells you, okay, do this case. That was the most difficult thing. And that was the most the gift of KM Hospital and gift of my seniors who were very big names in in craniovertebral junction and in neurosurgery. So combination of opportunity and combination of number of patients that were available, it gave a birth to this technique, I will say.
That's incredible to think that at the age of 27, you had achieved such great heights. I mean, it was amazing.
It is brilliant. So, and you said that it was very important to have a mentor and that you started in the lab to develop the technique. Could you please highlight some of the best points in your collaboration with your mentor, both inside the lab or also in the operating room?
See, here in KM Hospital, we had a very fantastic anatomy department. And also, uh, the head of Department of Anatomy, Dr. Manu Kothari, was a very big name in the field of neurosurgery, in the field of anatomy, and in the field of philosophy. So his presence itself was quite a dynamic presence. And Dr. Lahiri, you see, Dr. Lahiri was such a keen cadaver man that when we used to go to the cadaver dissection cadaver room, means it was a forensic postmortem hall, it was not anatomy department, it was a postmortem, and get a body to dissect. You see, in postmortem, they take an incision here in the midline in the chest to open and remove the organs and all those things. We used to do cervical dissections because this was open and cervical dissections were allowed. Allowed means nobody is allowed to tamper with the dead body. Nobody is allowed to take additional incision. So we used to open the mouth and do transoral surgery. For overnight, we used to do all night. We used to work with, to get a drill, to get a microscope in the cadaver, in the mortuary. It was not easy during those days to take we had a very preliminary, historic kind of a microscope. And also the drill system was very, very primitive. So we used to wheel the microscope in the mortuary and we used to work on cadavers. See, if we open the mouths, some dead bodies were to be disposed of the next day. So whole night they were available. And if we open the mouth and do our dissection and then just wrap it up, nobody would object. It was not correct, but this is what we were doing. And, anterior cervical, we did so many dissections. And then cervical dissections whenever it was possible to do in anatomy department and in cadaver department and mortuary and things like that. Dissection after dissection, not only craniovertebral, but we spent a huge lot of time in skull-based dissections, cavernous sinus dissection, temporal bone dissection. You will be surprised that I conducted a anatomy workshop in Japan, showed them cavernous sinus dissection, temporal bone dissection, drilling in 1992. This is so many years ago. And then I conducted several workshops in Japan, in Singapore, in various parts of the world. During that time, dissections and human dissections were not so much popular. They were there, of course, but not hugely popular like they are today. And my feeling is this exposure, this anatomy of this area is quite a complex anatomy. Nobody can actually understand unless he knows it very well. You know, you put a C2 screw, you can completely damage the vertebral artery. You see, let me see if I have a picture. You see here, this picture, the vertebral artery looks very, it looks very safe, but vertebral artery goes right inside the facet of C2. And when you put the C2 screw, you can damage the vertebral artery. Once it is damaged, how to control it is another issue. You cannot just leave a bleeding situation. You have to control that bleeding. If you are dissecting and you damage the artery over the arch of atlas, how do you control that bleeding? So it is not just anatomy, it is surgery. There is a huge venous plexus in this area. And to control that venous bleeding can sometimes be very difficult job. So to control the venous bleeding, to identify, and we didn't have navigation or all those things during those times. Even SIAMs were not there. So navigation came into picture much later, but SIAMs were used. Now, of course, I don't use any SIAM or any navigation or anything because I'm so much familiar with this area. But so much familiar does not mean that I can do it with my left hand. It is not like that. Still, it is a difficult operation. As I told you, I am getting more and more complex situations. Like today's case was an impossible case which I did. Both vertebral arteries were terribly into high riding artery into the C2 facet. I had to actually mobilize the artery. So there are various things to understand, to learn. And if somebody wants to learn this technique, first is he has to learn exactly the vertebral artery, how the vertebral artery. Then he has to learn the anatomy of the C2 ganglion. Then he has to know the facets. And then he has to learn the art of controlling bleeding, venous bleeding. And then he has to have experience of, it is not an operation which is, okay, let me try and let me try. You cannot try because when I say there are complications and far and few, but those far and few are huge complications. You can have a person who is quadriplegic, but he's fully conscious. That kind of complication nobody in the should have ever. He's conscious, he's looking at you, he's turning his head here and there, and he's not able to move, he's not able to breathe. That complication can be the most dramatic and dangerous complication in our subject. So you cannot have a complication. I'm not saying you will never have a complication. There can be complication, but those are dramatic. So you have to learn very, very meticulously, understand this area, understand atlantoaxial instability. And, as I mentioned now, we have gone far ahead in this area since those times. And now you must see some of my presentations on central instability, which is, in my view, a complete revolution. Now, if you ask me what have been the revolutionary steps in this operation, one is to do this fixation. Second step, revolutionary, which we introduced, that you can open the joint, manipulate the facet. That was the second thing. Third thing is manipulation and realignment of the facets. Realignment for rotatory dislocation, traumatic dislocations. The other thing is for irreducible dislocation. We said they are not irreducible. Earlier, transoral decompression was such a hugely popular surgery. Hugely means during our times we were spending transoral surgery was everybody's operation. Everybody wanted to do transoral surgery, whether it is orthopedic or whether it's neurosurgery. But now, how many times you go to conference, you see transoral? Nobody talks of transoral surgery. So to reduce fixed dislocation, that was the next major step in this operation. Then we introduced the concept of facetal distraction, open the joint and facet distraction. So that reduced basilar invagination, and we said that basilar invagination can be reduced and there is no need for transoral surgery. Then we introduced intra-articular spacers. Then we went further, and as I now mentioned, we introduced vertical dislocation, lateral dislocation, and the hugely new revolution, which I am repeating the word revolution, is the concept of central instability, which in my view has the potential to change craniovertebral junction surgery. The indications of C1, C2 fixation are much bigger. Earlier, the only indication was mobile dislocation. Now, all kinds of instability, so many types of instability are there to do fixation. That
Right. So this one's
Brilliant.
like an interesting question we have now. When you first presented your findings, like in a conference, how did the spine community react to this something which almost sounded probably impossible back in the day? And did you face skepticism and how did you respond to that?
that is all the time. During those days, when I say C1, C2 now, even now people are hesitant to do, even today, after so many years. During those days, only midline wiring and all. So there was quite a bit of interest and quite a bit of enthusiasm. I will say it was not negative at all. Nobody criticized it. People criticized my technique of basilar invagination when I said distraction can reduce basilar invagination. Many people very badly criticized me for that for many years. Now, of course, most craniovertebral junction surgeons are using basilar for basilar imagination distraction technique. So this technique I have presented in 1991 in North American Skull Base Society meeting, 1989 actually, in North American Skull Base Society meeting I had present. That was my first presentation, and actually, it was quite a amazing response because than anything else, I was a very young boy at that time, and people couldn't believe this kind of things can happen. So that was another negative thing for me. Other negative thing was that, coming from a little bit less developed country and presenting something unique was also not such a went into my favor. But ultimately, all in all, people have recognized it, people have taken it up, and many people, most people in the world of craniovertebral junction surgery are doing this operation. And with great success, so many articles, so many things have been published on this.
That's amazing.
Brilliant. You have a very deep understanding of the anatomy and the technique. And after all these years, do you think that there are still ways in which it can be improved? Or do you think that this is
No, of course, we can certainly, you see, my challenges are the kind of complexities. As I mentioned today, I did one case, and that case was such a dramatic challenge. Now I can say only I have finished my operation about 5, 6 hours ago. This boy has started breathing properly. His voice has improved. His limbs have improved. His tingling paresthesia in hands have gone. His spasticity in leg is reduced 5 hours after operation. This is a kind of a dramatic clinical outcome and recovery. But the technique is a challenging operation. It has to be further, whether it can be improved further, whether the instrumentation can improve, whether the metal can improve, whether the quality of arthrodesis can be improved by some artificial bone, some artificial material. I use iliac crest since the beginning of our technique. Iliac crest was jammed into the joint and was placed posterior to the posterior elements of C1 and C2. Quite a bit of iliac crest I use, and I continue to use that. Whether some newer, I had recently had one lady who was saying that I don't want my back to be operated. You use some artificial material and things like that. But I persisted, insisted, and she ultimately agreed to that iliac crest. But she was a little bit hesitant and reluctant. So you can have a situation. So whether the artificial material and things like that, whether navigation, which I don't use, should be used more regularly and always is another issue. I will recommend for young people, they must use navigation, at least in the initial phases. And they have to study the anatomy, it is not just cadaveric anatomy, it is the anatomy of the individual person. Vertebral artery can go deep inside. In some cases, it may be very outside in some cases. It may have an abnormal course in some cases. The bones may be abnormal. The bones may not be normal. The joint is quite rostral in basilar invagination when there is assimilation of atlas, when there is C2-3 fusion, when there is clipal file abnormality, when there is platybasia. The joint C1, C2 is quite rostral enough to identify, expose, and do. As I mentioned to you, I don't use occipital fixation at all, no matter what, whether there is assimilation of atlas, whether there is basilar invagination or whatever. So to expose a C1, C2 articulation in a basilar invagination situation is difficult. It's challenging because venous bleeding, this bleeding, that bleeding, sometimes there can be furious bleeding and you can lose your breath during surgery. And when you remember that this complication had happened in my life and this fellow had become completely demolished by surgery, you keep on thinking whenever you're doing, you remember, oh, that I hope the same thing does not happen to this guy. Vertebral artery injury can be a very fatal complication. Although it is not a very frequent complication, you damage the vertebral artery, it does not mean there will be a complication always, but it can happen. So there can be various issues. This is a major and supra major operation. It is a dangerous operation. It is a fantastic operation that has to be learned and that has to be performed. And the indications are increasing by days. So everybody will have to do it because now I'm saying it has to be done for carry, it has to be done for this, it has to be done for fixed dislocation, it has to be done for degenerative spine. I'm saying for cervical multi-level degeneration, you have to do C1, C2 fixation. I'm saying for OPLL, you have to do C1, C2 fixation in several cases. So my indications are very rapidly increasing, and I think young people should, get going with this technique.
Right. Yeah,
What
that's quite an insight into it. Like, it's very interesting, as you say, that your indications are rapidly increasing. That shows also how versatile the technique is proving to be now.
what advice would you give to young spine surgeons who want to innovate and push the field forward?
Okay, so let me give you some of my thoughts. So young spine surgeons should first become a good spine surgeon. Okay. Second thing is they should get opportunities to operate. They should work in situations where they keep on getting operations like public institutions, like academic institutions. You cannot start from the first day. This is a learning process. This is an ongoing learning process. This can be learned on cadaver, but has to be performed on the live human body. So yeah, unless you perform and go on performing, go on assisting, go on doing for young people, I will say that have the enthusiasm, have the will, and the way will be there. So don't think of just this technique. You can introduce young minds. As I mentioned, when I was 27, we introduced the technique of Clivus to C3 plate system for the first time in the literature when I was 28 or 29 years old. So young minds can be supple, young minds can be innovative, and don't underestimate yourself. So when you're assisting your senior or somebody, and you think that, no, I should have done like this, I could have done like this. So don't underestimate that thought. That could be the real thought, and you have to work on that. If you think sometimes that, oh no, this I could have done in this fashion, that fashion may be really. So first thing is try to have confidence in yourself. Second thing is get the opportunities to operate more and more and more operate. And the third thing is go on thinking and publishing. So from India, publications were not so popular, but now and even in India, everybody wants to publish. And publication is the key. And if you want to go beyond a line, publishing and publications are important. So even if there is a small technique, like we first introduced spinous process screws and spinolaminar screws. They look such an ordinary kind of a technique during that time in 1994. when we published this. But we thought that it is a strong technique, and now, it was worth publishing. Like I said, I introduced this clivus to C3 plating. That looked quite a dangerous, difficult operation. Even now, when I see those pictures, they are quite dangerous or difficult operation. But it is you get opportunities, you think about. Most important thing in our business of spine or business of surgery is we think about the patient first. We think about the welfare of the patient. If you think that I'm doing some kind of innovation and you harm the patient by some, inadvertent kind of thing, you cannot harm the person, because human body is at stake. You have to be very, very careful that whatever you do, if you are doing innovation, if you are doing something new, if you are getting into a different corridor, you have to first be very, very sure that you are in a safe corridor, in a safe umbrella. You cannot go beyond and also reasonable with lot of thinking. And the last thing I will like to say is for young people, that not failure, but low aim is a crime. You don't keep your aim as just I want to become the good neurosurgeon or a good spine surgeon or a good orthopedic surgeon. You should have aim like I want to become the best in the world. That kind of high aims, if you keep, then only you can reach to a level. And I think that ambitiousness, that was very much ingrained in my character. And that probably took me well, and opportunities, of course.
Brilliant.
That's very inspiring. So, coming to the end of this interview, we have just one last question. It's, if you had to describe spine surgery in one word, what would it be?
In one word,
Yes, sir.
spine surgery is philosophy. Philosophy is my word, philosophy. You have to understand the concept, understand the philosophy, understand the mechanics, understand the biomechanics, understand. You see, now if you have read, just to divert a little bit, if you have read my recent work on spine, I say osteophytes is not a problem. I say ligamentum flavum buckling is not a problem. I say OPLL bone formation is not a problem. They are secondary to unstable spine. You must read my research. So if you have this concept that instability is the issue and compression is just a radiological observation, what we do is we observe that there is compression on radiology, on MRI, and then we go after that radiological observation. So we are actually treating images more than we are treating the real person. So there are various issues in spine, understanding the fact that we human beings stand on two legs, like no other animal on the planet. We stand on two legs. All our muscles are on the back of our spine. You put your finger, you can touch the odontoid process. You put your finger here, you can touch the cervical bones. But all our muscles have the act to make us stand. They pull us in standing position or sitting position. So keep your muscles strong, keep your muscles exercised, and keep standing. If you keep your muscles weak, if your exercise not enough, you will stop standing, and then that is degeneration of spine. So instability is the result of weak spine. So there are many issues. So my one word answer to spine surgery is philosophical. It has to be patient-oriented philosophy, understanding, and treatment.
That's beautifully put, sir. An amazing word to choose as well. So thank you so much for joining us today. I think when I speak for Raris and myself that we feel incredibly lucky to have had this, interview session with you. And I'm sure this would also be a source of inspiration and motivation for all the young spine surgeons of our AO Spine Youth Club, and also the other viewers who would be watching this video soon. It has been a true privilege, sir. Thank you so much.
Thank you, Ares. Ares, from where are you?
I'm from Denmark.
It's so nice I know Denmark as country of footballers, country of tall and handsome people.
That's
best
true.
wishes.
And also the country of Hugo.
So best wishes to both of you and all of you. Thank you very much. Bye-bye.
Thank you. Thank you for your time again. Bye-bye.